Hi, this is Brian Kim. I'm going to share with you case number 74 in the best way to do cataract surgery series. This is a soft lens, and this is also a patient who had radial keratotomy. You'll see double chop, cross chop, mechanical fracturing, and how easy and efficient it is to chop this very soft lens. And now place this Toric IOL at axis 60, and you'll see how I do that here. So you can see I've pre-marked the patient sitting upright in the holding area. I'm using a cotton tip to hold the eye and then using a corneal marker which will help me to center and size my rhexis. And this is my paracentesis incision, 1mm blade. I'll be making on the right side and then left side. I'm going to make the incision flat to the iris plane to get a nice corneal shelf, making sure I avoid the RK marks. Having that nice horizontal shelf is really important to be able to easily achieve a self-sealing incision. I'm injecting some intracameral lidocaine and then now some intracameral dispersive viscoelastic to fill the anterior chamber and coat the corneal endothelium. I intentionally placed my paracentesis in such a way that I knew about 90 degrees which will be in between the two RK incisions. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel into the cornea, and then enter. And I wanted to make sure I was in between the two RK incisions. So this is the puncture style rhexis. I puncture the center and I'm pulling downward towards my incision and I'm grasping on the right side to create a flap. And I'm just very carefully teasing the edge of that flap because where I grab it will really dictate and determine the size of the rhexis. So once I grab it, I go around circumferentially, grabbing and re-grabbing every few clock hours. And I'm trying to follow the corneal mark that I made earlier. Which will hopefully allow me to achieve a well-centered and sized rhexis. So I finished the rhexis and burped the viscoelastic, and this will be the Capsulorhexis hydrodissection technique. I place the cannula underneath the rhexis edge contra-incisionally, place the tip pointed down, get a nice wave, decompress on the left side, turning the cannula tip to the right, pointing it down, and this allows me to hook the lens, and now I'm able to spin it freely and easily. I'm going to irrigate the surface of the eye and making sure my sleeve is adequately positioned. Lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. I'm going to remove the surface epinuclear material and place the chopper underneath the rhexis edge, contra-incisionally, point the phaco tip vertically subincisionally. Since both instruments are in the equator, when I pull them toward each other, they fracture the lens in half. I place the chopper around the right heminucleus, hooking it, pulling it centrally towards the phaco tip, and crushing and bisecting the right heminucleus. That is the double chop and cross chop respectively. I lift that first quadrant up and start crushing it between the chopper and the phaco tip and emulsify the lens piece. You can see again, this is a fairly soft lens. Placing the chopper around the second quadrant, pulling it centrally, dividing that lens. Again, that's a cross chop maneuver. Once that piece is loose, I grab it with some vacuum, crushing it, and then emulsifying the lens piece. Turning the lens and grasping that last piece of the second quadrant, pulling it up out of the bag, and then crushing it between the chopper and the phaco tip and emulsifying the lens piece. Turning the second heminucleus in front of me, placing the chopper around the lens piece, down to the level of the equator, pulling it centrally toward the phaco tip, crushing and dividing the lens. And then using successive mechanical fracturing forces, sandwiching and crushing the lens piece, that third quadrant into smaller and smaller pieces, and then emulsifying the lens piece. Hooking the fourth quadrant with the chopper, pulling it up, crushing it, sandwiching it, making it smaller between the chopper and the phaco tip by crushing it, and then emulsifying the lens piece. Now removing the epinucleus, starting from front to back, from anterior to posterior, and the epinucleus tumbles out nicely here. I always keep the chopper deep in the bag when I do this. I take the chopper out, push BSS in, take the phaco tip out, and go in with the INA handpiece. I start to go underneath the rhexis edge, looking for any cortical material to remove. I'm using foot pedal modulation to make sure I don't use too high of a vacuum, which might accidentally grasp the capsular bag. But it looks pretty clean, so I switched to polish mode, and I'm more aggressively polishing underneath the rhexis edge, looking for any cortical material and also removing lens epithelial cells. By switching to polish mode, you can be more confident that you're not going to accidentally pull on the capsular bag and cause any zonular problems. Now I'm going into the subincisional space, trying to tease off any cortical material that's there. I'm just rotating the tip in order to get to that. And then I'm polishing the posterior capsule surface a little bit and polishing under the rhexis edge again. And I'm polishing the posterior capsule in the subincisional area as well. This will help loosen any potential lens material that's in the subincisional space. So once this is done, I'm going to place the BSS cannula through the paracentesis, carefully place the cannula tip underneath the rhexis edge subincisionally, and then I'm going to gently pulse. As I pulse, you can see there's wisps of cortical material that are coming out and getting loose. And then I'm grabbing the loose edges with the INA handpiece, again under polish mode, and I'm able to more easily remove the material. If there's still some stubborn material that I cannot flush, I'll go after it with the capsule sweep later on. So I go ahead and inject some cohesive viscoelastic to fill the capsular bag. And now I'm going to use the capsule sweep and starting in the subincisional area, going after some of that fine cortical material that was left. And as I sweep into the subincisional space, you can see that the cortical material comes out really nicely here. Again, it's easy to miss that cortical material if you're not looking for it. And so it's very important to either flush or sweep into that space. Because remember, when you fill it with viscoelastic, it pushes everything back. So go ahead and inject a single piece acrylic intraocular lens into the capsular bag. Again, this is a toric lens, and so I'm going to reposition that lens and rotating it so that the marks are at about 60 degrees. So I go in with the INA handpiece, irrigation off, activate irrigation, and then I'm carefully teasing off the haptic off the optic, go underneath the lens, rotating it about 80 degrees there, removing all the viscoelastic from within the bag, repositing the lens back into the capsular bag, switching to polish mode. I like to go to polish mode here so I can much more confidently and vigorously polish underneath the rhexis edge. There's invariably some very fine lens material that's attached and adherent to the rhexis edge there. So I switched to visco mode to remove all the viscoelastic from the anterior chamber. And so now I'm going to low mag. I've noticed more lately I'm going to low mag because it just gives me a little bit of a better view of where I'm supposed to position the lens. And so you can see I'm at about 70-ish. I just have to rotate it a little bit clockwise to get to 60. And so rather than doing anything unusual, I'm just using the INA tip to kind of nudge the lens into position. And I'm doing this under active irrigation. And so that's very important. Nudging the lens when the eye is collapsed makes no sense because all you're doing is pushing the zonules and stretching the zonules. Anytime you're positioning the lens, you really need to do it while the eye is actively being inflated. If you're not doing that, again, you're just pushing on the zonules and stretching the zonules. So once the lens is in position, again, under active irrigation, you can be confident that the lens has indeed rotated within the bag and it's in the correct position. And then you quickly switch. I pull the irrigation and aspiration handpiece out, and I'm actively pushing BSS into the eye to try to keep the chamber stable. And then I quickly hydrate my incisions. By doing it this way, I feel like by minimizing collapse of the chamber, you just are able to maintain the position of the lens in the way you wanted it. And so here's the access ring. I'm placing the marks in alignment with the ring, and you can see it's spot on at 60 degrees. So again, I rotated it clockwise just a tad, again under active irrigation, which means I'm able to definitely position it correctly. If you just did it with the eye collapsed and you tried to rotate it, when you are at this step, when you're hydrating your incisions and filling up the eye, you'll see that the lens will be not in the correct position. Because again, you really didn't move it. You just pushed the zonules when you did it. And so in this way, you can be very confident the lens is in the correct position. Again, in this case, it's 60 degrees. I check it one more time here. I ask the patient to look straight at the light, and it's perfectly aligned at the 60-degree axis. So I hope this was helpful to you, and I thank you for your attention.